So to kick off our session, our first session, the quality of care in clinical obesity services, and our first distinguished speaker is Ramy Bishay, and Ramy is a staff specialist and clinical lead of the metabolic and weight loss clinic at Blacktown Hospital. He's also staff specialist, endocrinologist and general physician at Canterbury Hospital. He did his endocrinology and physician's training at St Vincent's, Concord, Blacktown and St George Hospitals. He also worked privately in Fairfield and Bella Vista. Ramy was a lead in establishing the multi-specialty metabolic obesity clinic in 2017 at Blacktown Hospital, which is slated to become one of the largest programs of its kind in the country. So would you please welcome Dr. Ramy Bishay to the podium. Thank you.
Thank you, Evan. My accent is not entirely Australian, it's actually Canadian as well. I'm actually quite honored to present after my fellow countrymen. When my supervisor for my master's degree at the University of Toronto left to go to a place called Calgary, I said, has anything good come out of Calgary? You know, where is that part? Because people in Toronto are a bit like Sydney, they think that's the only part of the country that matters. It's good to know that something great came out of Calgary. Now, I'm tasked with the very, very easy responsibility of summarizing all obesity treatments in the next 15 minutes. So pardon me for my this is going to be a bit of a shock. So, unfortunately, I lose a lot of obesity pharmacotherapy in my private patients. I consult for half the week, and the other half the week, seeing very obese patients. On average, our patients are about BMI 55, mostly female, as one would expect. With a lot of comorbidities, Edmonton obesity stages 2 and 3 for the most part. So obesity interventions can be summarized very briefly into intensive behavioral lifestyle treatments, pharmacotherapy, and bariatric interventions. Unfortunately, because it's 15 minutes, I'm going to blast through some of these things, looking at the direct trial and the CSIRO total well-being diet, the MDT, and my early experience with a man named Nick Cormiss at Concord, and the Blacktown program, and then talk a little bit about pharmacotherapy in 1-minute intervals each, using cases. So I want you to, now that you've had caffeine soaring through your veins, you're just gonna absorb everything I've said. This is a direct trial, we know about this, and if you haven't, this came out just as I was finishing up endocrinology training. I'm very junior, I shouldn't even be up here. But you can see that people on average lost, 24% of people lost 15 kilograms of weight if they did the Cambridge meal replacement diet, so similar to like OptiFast or OptiSlim. And they did 15,000 steps a day. They had to have done this program for about 3 to 5 months. Average BMI is about 35. Average weight was about just over 100. The people who achieved diabetes remission, which was, they looked at HbA1c less than 6, that's how they did find it in the UK. And for this study, it was for about 46% of people actually achieved that. But it was a dose-dependent relationship with weight loss. So if you lost 15% of your 15 kilograms or more, there was an 86% chance you're free of diabetes based on HbA1c by the end of that 1-year intervention, which is huge. And this was carried on after 2 years. Now, if you haven't used VLED, this is a nice, easy, free resource. We've got another complex one that we use at Blacktown, which Sarah, our dietitians, put together. But if you want one, you can use this. This will just basically Google Baker IDI, VLED. You get something for the people who haven't used it before. Now, I want to talk about CSIRO because VLCD doesn't work for everybody. And I think using an Australian Guide for Healthy Eating doesn't really help a lot of people either. It's probably good for weight maintenance, people with a normal weight. But to lose weight, there is some evidence for CSIRO. Look it up, you can Google it, you pay for a 12-week subscription. If you lose weight, you get that money back. And on average, they quote about 5.3 kilograms loss of weight. But people with diabetes, actually, there's a different trial, and it's backed up by many decades of science, that if they did a lower carbohydrate diet and their fats came from unsaturated, i.e. non-animal sources, they actually had lower glycemic variability, improvement in the lipid profile, and more weight loss. So I think there's a one-size-fits-all analogy I think is debunked by now, but specifically, if you have someone with diabetes, you should be looking at a lower carbohydrate diet. I think the evidence is very strong on that. You can come and fight with me afterwards for lunch. Now, lifestyle programs, we know about the Finnish diabetes prevention study. This stuff is old. I'm not going to kind of rehash this stuff. We know about this is the diabetes prevention trial, and we know about the Look Ahead trial, which looked at, everybody had, exercise, counseling, group sessions, some weight loss, some weight regain, all kind of modest weight loss. Does this stuff, like what Professor Sharma was saying, is this stuff really kind of depressing? Do people just regain the weight? There's modest weight loss with whatever you do. But I think long-term, and this is a small study. When I was a naive third-year med student, I met a man named Nick Cormus. I just got married. I'd lost about 20 kilograms at that point. I still lost another 20 kilograms after that doing my own lifestyle, and I got really interested in this stuff. And then I said, well, let's look at your obesity patients. Dr. Cormus, now I call him chairman, and he says, okay, well, let's follow these patients. And you won't find this data anywhere, but if patients exercise 3 times a week on average, and they saw the endocrinologist every 6 months, and they saw a dietitian every once in a while, and a psychologist, not only can they maintain the weight loss of about 10 to 12 kilograms or 10 to 12%, because their average weight was about 100, but they can actually keep it off at 30 months. You will not find this data anywhere. Even the HbA1c reduction as well, 1% reduction, that's like a GLP-1 receptor analog without the cost of a GLP-1 receptor analog. Comparing that with, so we got the metabolic rehab program, MRP, which is the program I'm describing. It's an MDT clinic versus diabetes clinic in DC. What it shows is that if you have diabetes, you should not be going to a diabetes clinic. You should be going to an MDT clinic. Here's a psychologist, physiotherapist for weight loss. That's your treatment for your diabetes. I should not be throwing in, medications necessarily. You should not be seeing a diabetologist. If anything, you're probably going to diabetologist will make you put on weight. Mind you, this was before the era of GLP-1 analogs and SGLT2 inhibitors. So MDT beats standard clinics in my opinion. Maybe not now because we didn't have the newer agents. And this is our data from Blacktown. We looked at people who've had bariatric surgery. Again, just over half were female. Average BMI was about 50. Average age 50. Most had sleeves. And we know that weight loss is important if you're in a bariatric center because pre-bariatric weight loss does predict post-bariatric weight loss. In fact, people who if we looked at weight loss as a binary variable, when you correct it for a whole bunch of other things, that if you lost more than 25% of your excess weight, if you lost weight preoperatively, there's a greater chance you're going to lose weight postoperatively as well. I think Nick Cormus's group is also publishing some data in ANZOS. Now, this is what our program looks like. We have an orientation session. We have an initial workup with lots of cardiometabolic things and pituitary panel. We do a medical assessment. Our nutrition program, which is designed by our excellent dietitians, Sarah and Caroline, sitting just in front of me there. They go through a period of meal replacement, which is based on a direct trial. So this is evidence-based treatment. Then they go on to something similar to a CSIRO diet, maybe crossed with Australian Guide of Healthy Eating. There's an integration there, reliance on more higher protein, lower GI sources to help with satiety and preserve lean body mass. And then a little bit of MDT philosophy with Nick Cormus in there. And then we got, and these success stories, should I go back then and just show that? There he is. Yeah, right. And people will go to medical review and then they're slotted into either surgery or non-surgical pathways. So if they're doing really well, they want to continue, they want to ride the wave, we continue them in a maintenance program. Whereas people indicated for surgery, they proceed to have surgery. We do insist on some weight loss because we know it is helpful, not only for reducing complications, but also for patient motivation and adherence. Now, these success stories, there's one thing in common with all of them. None of them have had bariatric surgery. Look at the weight loss with the VLCD, 72 kilograms, diabetes remission, 43 kilograms, diabetes remission, 26 kilograms, diabetes remission, 23 kilograms on the bottom here. HbA1c came down from 9.8 to 6.3. Insulin was more than halved. So it does work. Now, Arya's perfectly right. They've lost weight. Can they maintain it? That's what sifts between the champions and the temporary winners. Me, myself, I've lost 40 kilograms. I should put myself as a success story. I've kept it off for 10 years, and I tell my patients, you can't do it long term. Now, some cases, the iPhone 11 Pro is on pre-order as of yesterday, so I just put this up anyway, just in case you guys were up. 52-year-old female, she's a lecturer veterinarian. She saw me in my private rooms with Edmonton obesity stage 3. She was seen at 125 kilograms, and Georgia's going to tell us about weight regain in a moment, but she came in after regaining some weight after a sleeve gastrectomy. Basically, she was going in to have her redo, she's going to have a bypass surgery, but then she changed her mind. The surgery said, just call things off, send you to this poor guy named Ramy Bishay. Unfortunately, she developed idiopathic cardiomyopathy, probably viral in origin, with this weight regain, and she was really scared about her mortality. Up to a third, maybe even half of women in our program, 2/3 of our women in our program have had some sexual abuse in their past. In the community, I don't know what that is, but in our program, it's very, very high. And no surprising, she had a history of sexual abuse by a gynecologist, and binge eating and depression. So which one of the following therapies may be appropriate to trial in this patient? Is it Germine with topiramate, Saxenda, Contrave, Rolosal? Can I have a show of hands for the first for Germine? How about Germine with topiramate? Saxenda? Potentially, yep. Good. Contrave? All right. Orlistat? Probably doesn't work too well. Or lorcaserin is not available, so So we said Saxenda because she had heart failure. You don't want to use Duromine. She has depression. You probably don't want to use Dupyramate. Saxenda is probably the best option of those. Contrave, again, because of the heart rate, hypertension, the depression as well, and then it's oral citalopram. So we did do that. 6 weeks later, she lost 8 kilograms. She's feeling good. Mind you, this is all with VLCD as well. She celebrated her 50th birthday. And even with occasional breaks in Saxenda, I kept saying, go back on it. 12 weeks later, she lost 15 kilograms and a few other things. So Saxenda works by regulating appetite, by increasing satiety at the level of the hypothalamus. It binds GLP-1 receptors in the hypothalamus and the gut, mostly the gut, but a little bit in the hypothalamus as well, and reduces food intake, but doesn't change your metabolism. It works by regulating your appetite mostly, and it also slows down your gut, so promoting feelings of fullness. I'm only going to show one slide on this because the scale studies have looked at people with sleep apnea, pre-diabetes, and people with diabetes. On an average, you lose about 8 to 11% of body weight. On average, if you can lose 5% of your body weight initially in the first 4 months, you probably will lose on average of about 11.3% body weight long term. So there's the whole concept of early response. But on average, if you subtract placebo, now mind you, all these people were on some calorie-restricted diet as well. So it's, you can't just use minus placebo. They actually did get treatment of some description. This is a case 2, Mr. CG, 23-year-old male, admitted with DKA for diabetic ketoacidosis. He had pancreatitis from high triglycerides. He was an inpatient with 143 kilograms, Edmonton obesity stage 3. He was managed with insulin, other oral therapies, which we managed to get him off. He's quite a young guy. He didn't have type 1 diabetes. I checked. I did some blood work. And then he eventually saw us in the clinic. He's on metformin and fenofibrate. And which one of these therapies is not appropriate to trial in this patient? Put your hands up for Duromine. It's not appropriate. Duromine or Dupyramate. How about Saxenda? Contrave. So orlistat, lorcaserin. So he's had pancreatitis recently. You don't want to be using a GLP-1 analog yet. So 6 weeks, he was on a VLCD. He lost 9 kilograms, but he said, you know, I'm really hungry. So we said, okay, let's give you a touch of Duromine and maybe some Dupyramate as well, which we combined together. So Dupyramate is a downer, Duromine is an upper. So you can kind of split the doses. Sometimes what I do, if cost is an issue, I compound them at a compounding chemist, get a little bit cheaper. Inova's not here, so they won't get upset me saying that. So you can get it compounded, and you have to use the Q-Simia doses. So I'll show you a bit of data about Q-Simia, which is the combination of phentermine or Duromine and Dupyramate. 12 weeks later, 17 kilos. 16 weeks, 21 kilograms. He forgets to eat. That's very common with Dupyramate. People just forget to eat. They'll just stop eating, which you're kind of thinking that's kind of good, kind of bad. So they need to be having enough nutrition. At least put them on a multivitamin and get some extra protein intake. And now he's in diabetes remission. Duromine suppresses your appetite. It's a sympathomimetic amine. Basically, it's a rever up of the engine. It stimulates the effects of the body's sympathetic nervous system and acts on the hypothalamus by increasing noradrenaline in the presynaptic and the postsynaptic region. And the average weight loss is when you minus people on a very low calorie diet is about 5 kilograms, but altogether you're looking at between 8 to 11 kilograms of weight. The tolerability is, I think, scares people, but I have not had anybody with significant insomnia or tachycardia or cardiomyopathy or whatnot. It's mostly insomnia you have to worry about. If you're worried, I usually start with a medium dose and titrate up and down. So you can start with 30 milligrams and go down to 15 if sleeping is a problem, or up to 40. What you can do also, you alternate daily. So they can do Duromine alternate daily. That actually works just as effectively. Or some people do alternate weekly, week on, week off as well. So we know about some of the adverse effects. It's been around for donkey's years. The cardiovascular things, the palpitations, tachycardia, hypertension, nervousness, agitation. So be mindful of your patient. But if you're ever worried about these things, you can always discuss that with them and be mindful of that, and also initiate early reviews, which is what I tend to do. Constipation is another neglected one as well. Now, phentermine Dupyramate does have evidence. If you look at the evidence for this, looking at the different doses of phentermine, this is a weight loss on the y-axis. This is time on the x-axis. You look at the bottom curves there. I think it's this one here. That's phentermine, 15 milligrams with Dupyramate, 96 milligrams, which we don't have in Australia. It's about 100 milligrams. So I tend to use this combination either as a compounded, or I'll give them phentermine 15 mono and Dupyramate 100 nocte to get this kind of effect. Or you can do various combinations, or 7.5 over 46 milligrams Dupyramate. Now, this is my last case, 48-year-old married female, 2 kids, works full-time. She's post-bariatric surgery again with a sleeve gastrectomy 2016, referred by her surgeon. maximum pre-op weight was about 110. Got down to 70. She did well with surgery, but not, most surgeons will like at least 50% excess body weight, if not around 60. And she's currently stable, but she's got significant back pain issues. Wants to lose weight to improve her mood, dislikes the idea of injectables. She tried Ramy, didn't work. And background is listed there, preeclampsia and gestational diabetes, but mentally very stable. Which one of the following therapies may be appropriate to trial? Thank you, Evan. Ramy, I'm trying to make this interactive, so it might be hands up for Ramy, maybe effective trial. I told you she didn't respond to it. Maybe add topiramate perhaps. Saxenda, I mentioned she doesn't like injectables. Contrave, yes, okay. Yeah, we'll try Contrave, why not? Which we did 6 weeks later. 8 kilograms were off, no breakthrough hunger. She had a mild rash, which resolved, and no increase in pain and seizures and blood pressure, and it was well controlled. With Contrave, you usually get the first 4 weeks, you might get a bit of nausea, sometimes vomiting, sometimes dizziness, kind of mild symptoms for the most part. 12 weeks later, she lost 12 kilograms and feels well. Mind you, again, I did a bit of VLCD with her as well. Bupropion, what Contrave is, it's naltrexone bupropion. So they basically gang up on this very special neuron in the hypothalamus, and the arcuate nucleus of the hypothalamus to regulate appetite. So you got bupropion ganging up on the POMC neuron, basically saying fire away, and the naltrexone is preventing its negative feedback. And they basically get this overactivation of the POMC neuron to get the effect. And there's a couple of trials now. The CORI, which is basically more mild Edmonton obesity stage 1 type patients, whereas the CORI BMOD looked at very intensive MT-style weight loss with exercise, diet, etc. And CORE DM is looking at people with diabetes. So the best case scenario, minus placebo, you can actually get between 5 to 6% weight loss, but sometimes you can get a bit more, like in Our Lady. So it's very individual. This is how you take it. You start with one tablet in the morning for 1 week, then 1 and 1, then week 3, 2 and 1, then week 4, 2 and 2. Advise the patients in the first 4 weeks, you might get some side effects which will abate over time. I got rid of the side effect, but you shouldn't be starting it in somebody with seizures, people on monoamine oxidase inhibitors, opiates. There's a lot of list of contraindications and precautions. What's in the future is tirzepatide, is dual GLP-1 analog and GIP receptor agonist, which has very similar weight loss efficacy to semaglutide, which is just recently published its cardiovascular outcome data literally a week ago. That's the oral semaglutide, whereas the injectable one has been TGA approved in Australia, I think 2 weeks ago. So they're seeking PBS funding. Come on, Novo, you can make it work. Lorcaserin published its cardiovascular safety in the NEJM last year, but it's not available on Australian shores yet. And endoscopic procedures is an up-and-coming field. These are the people I work with. Got Professor Michael Eadie. Gola Allenstein is our gastroenterologist and liver specialist. I've got lots of people, diabetes specialists, pituitary specialists. I've got a fantastic team, Sarah, our senior dietitian, Annette, our CNC, and Caroline, who's joined our team just this year. And we've got a fantastic physio. And Allison, who can make it, and just had throat surgery a few days ago. So thank you for that, and thank you very much for your time.